Good afternoon, dear students. Today we start our ophthalmological lectures. Before our lectures, I would like to introduce myself. My name is Anna Kapayenko. I am a professor of ophthalmological department. I will deliver lectures in ophthalmology. Before our lecture, I would like to congratulate you with the beginning of the new academic year. I hope you will receive a lot of new knowledge. You will find a new friends. Okay, but today we start to speak about ophthalmology. Our first lecture, Introduction to Ophthalmology, Clinical Anatomy of the Organ of Vision. I hope you know that all people receive 90% of the information of surrounding world with the help of vision. Blindness is a great problem all over the world. It's not just ophthalmological problem. It's a great social problem. And 40 million of people are blind. In Russia, near 100,000 people are totally blind. So I hope you understand that ophthalmology and management of the ophthalmological patient are very important nowadays. What is ophthalmology? Ophthalmos is a Greek word, it means eye. Ophthalmology is a branch of the medicine that deals with the anatomy, physiology, and diseases of the eye. Ophthalmology has a great history. Even before Christmas, a lot of the surgeon, a lot of the doctors think how to treat ophthalmological diseases. And I think that there are some students here from India. And I hope you know that there was a great surgeon, Sukruta, who also could treat ophthalmological diseases. In modern history, ophthalmology started to grow, to develop very quickly in 18th century. In this period appear the great ophthalmology such Helmholtz and others who invented ophthalmoscope and other ophthalmological devices. In the Crimea, ophthalmology started to develop quickly in 20th centuries. In 1923, in Simferopol, was created the eye clinic in Tavritsky Medical University. In 1925, the medical faculty was closed. It's a pity, but the clinic continued its works. In 1935, the Department of Ophthalmology resumes its works under the direction of Professor Belsky. After the World War II, the work of the department was headed by the well-known scientists as Professor Medvedev, Professor Azarova, Professor Tetina, Professor Moskovchenko, and Professor Litvinenko. Since 2006, for present times, the head of the department is Professor Ivanova. I hope you will meet the head of the department, Professor Ivanova, during our practical classes. Maybe she will deliver some lectures to you. Before our speaking about anatomy of the eye, I would like to tell you some words about what is ophthalmology today. Ophthalmology today is a branch of the medicine which develops very quickly. New equipment, new devices, new technologies appear every day. I hope you know that nowadays a lot of people operate uh, cataract. Cataract surgery nowadays it's a mm, outpatient procedure with a small incision or with intraocular lens, modern intraocular lens, which helps to people to receive absolutely new vision for far, near, and middle distance. Ophthalmology today, of course, is a retinal surgery. New microscope, new small incision and devices helps us to work in vitreal cavity. This surgery helps us to operate retinal detachment, hemorrhages, complication of the diabetes mellitus. I hope you know that nowadays pathology of refraction are very often. Maybe you or your colleagues wear glasses or contact lenses. Myopia is a like non-infection epidemic, and nowadays, all over the world, we see new method of correction of myopia, hyperopia, and astigmatism. This is excimer laser surgery. Excimer laser surgery helps us to leave glasses and contact lens. So, as for me, I'm excimer laser surgeon and work not just in the ophthalmology department of university. I also work in a private hospital OCA center where I make excimer laser surgery. We have modern equipment, two lasers, which help us um, to operate people with refraction anomalies. Okay, but now we should study anatomy of the eye. Maybe at first sight it's a little bit boring, but you should know anatomy and then we can go further. Organ of vision consists of two basic parts: visual analyzer and accessory ocular apparatus. Visual analyzer consists of three parts: peripheral, pathway, and central part. Accessory ocular apparatus or ocular adnexa consists of orbit, eyelids, lacrimal apparatus, extraocular muscles, and conjunctiva. Visual analyzer has five neurons. First two neurons are situated in the retina. First neuron, photoreceptors, rods and cones. Second neuron, bipolar cells. Third neuron, multipolar or ganglion cells of retina. Axons of these cells form all parts of conduction tracts, visual nerves, optical chiasm, and visual tracts. Fourth neuron locates in gellicular bodies. It exons from glassolar radiation and passes through the internal capsule, finish in occipital lobe cortex. Fifth neuron is located in occipital lobe. Eyeball weight of the eyeball is 7-8 grams, diameter 24 millimeters. You see, here is the eyeball. On this picture, you can see the eyeball in orbit. Here, the orbit. Here, the extraocular muscles, eyeball, optic nerve. This is eyelids. At first, we should discuss coat of the eyeball. The eyeball has 3 coats. External eye coat is called fibrosis or cornea sclera. The middle layer, vascular tract. The internal layer, retina. We start to speak about fibrosis layer or cornea scleral layer. Look, this is fibrosis layer. This layer consists of cornea. This is cornea, transparent part of the fibrosis layer, and sclera, opaque part. Cornea consists of 5 layers: epithelium, Bowman's layer, stroma, descemet membrane, and endothelium. Cornea is transparent structure and has unique properties. I have already mentioned that cornea is transparent, brilliant, glassy, smooth, high sensitive, spherical, and avascular. According to these properties, cornea has the following function. The first, light passing, light refraction. Refractive power of the cornea is 40 diopters. Cornea maintains the eyeball form, and of course, cornea is outer layer. That's why cornea has protective function. Cornea transparent and avascular structure and receive nutrition from pericorneal limbus plexus, from intraocular fluid, and from lacrimal fluid. Cornea very sensitive and receive sensitive innervation from ophthalmic nerve and sympathetic innervation from the cervical sympathetic plexus. So now we should discuss the second part of the fibrosis layer, sclera. Sclera opaque, white color. Sclera has protective and support functions. Place of transmission of the cornea into sclera we call limbus. Limbus is a very important part because there is limbus plexus which gives nutrition to the cornea, and also limb is important growth area for the corneal epithelium. So we go further. We have already discussed. We discuss outer fibrosis layer. Now we should discuss vascular tract of the eye. Vascular tract of the eye consists of the iris, ciliary body, and choroid. Three parts. Iris. Iris contains pigment cells, melanocytes, and these cells give the color to the iris. Also, there are ocular muscles and narrowing the pupil and radial extending it. The main functions of the iris are regulate the amount of light that enters into the eye and participate in the intraocular fluid movement and accommodation. Motor innervation iris receives from oculomotor nerve, sympathetic innervation, innervation receive dilatator muscle. Sensitive innervation iris receive from ophthalmic nerve. Iris receive blood supply from long posterior ciliary artery, anterior ciliary artery, and these arteries form a large and small circles of blood circulation of the iris. Pupil is a hole in iris, and the iris controls the size of the pupil. When you're in a light, bright room, our pupil is constricted. When we're in a dark room, our pupil is dilated. I hope you remember from physiology course about pupillary reaction. There is direct and indirect reaction. Direct reaction when we enter light into eye and pupil is constricted. When indirect reaction, when we enter light in one eye and the pupil from the other eye also is constricted. Ciliary body is the second part of the vascular tract. Consists of processus part and flat part. Ciliary body contains muscles, vessels, nerves, pigmented cells. The main function of the ciliary body are production of intraocular fluid and taking part in the accommodation. A ciliary muscle receive motor innervation from oculomotor nerve, sensitive innervation, ciliary body receive from ophthalmic nerve. Blood supply, ciliary body receive from long posterior ciliary arteries and anterior ciliary arteries. The third layer of the vascular tract is choroid. Choroid consists of three main layers: brush membrane, choriocapillaris, and stroma. Choroid participates in visual act, restoring visual pigments, participates in the nutrition of the outer layers of the retina. Blood supply choroid receives from short posterior ciliary arteries. On this picture, you can see the blood supply of the eyeball. So, if you remember, here internal carotid artery and ophthalmic artery is a branch of the internal carotid artery. Ophthalmic artery gives some branches: the central retinal artery, the lacrimal artery, posterior ciliary artery, short and long anterior ciliary artery, and muscular arteries. I have already mentioned which arteries supply some structures of the eyeball. We go further. The third layer of the eye, or the third cord, internal cord, is retina. This is the most important cord of the eyeball. Retina consists of optical part and blind part. Retina has three neurons, as I have already mentioned. First neuron, photoreceptors; second neuron, bipolar cells; third neuron, ganglion cells of the retina. Now, we have already mentioned about third, fourth, and fifth neuron. There are a lot of layers of the retina. I don't ask you to memorize all of them, but you should know three neurons of the retina, and you should imagine that structure of the retina are very difficult because it's a very important part of the eye where the image transmitted is transmitted to nervous impulse. If you will be ophthalmologist, you will study all these layers: pigmented epithelium, layers of rod and cones, external limited membrane, outer nuclear layer, outer plexiform layer, inner nuclear layer, inner plexiform layer, ganglion cell layer, nerve fibers layer, and internal limited membrane. When we examine the patient, we see the fundus of the eye and we see retina, vessels of the eye, and we see optic disc. So this is optic disc. This is central part of the retina which we call macular area. Here you see vessels. These are branches of central retina artery and vein. You can see the picture of the normal eye fundus. In a case of pathology, we can see here different anomalies. For example, bleedings, exudates, and other problems. Optic nerve is formed from the axons of ganglion cells of the retina. There are four parts of the optic nerve: intraocular part, very short optic disc; intraorbital part; intracanalicular part; and intracranial part. The length of the optic nerve near 45 millimeters. A visual act is a very difficult photochemical process in photoreceptors of retina convert the image into the nerve impulse. Then the nerve impulse is transmitted through the visual pathway in the central section of the visual analysis, which is converted into a visual image. We have already finished chords of the eyeball, and now we should discuss internal contents of the eye. Eye has anterior and posterior chambers, crystalline lens, and vitreous body. Here, anterior chamber, posterior chamber, and vitreous body. Anterior chamber is bounded by cornea anteriorly, by the iris and papillary pad of the lens posteriorly. Posterior chamber is limited by iris anteriorly, by lens and vitreous body posteriorly. Chambers are filled with intraocular fluid. There is also a very important part of the anterior chamber, angle of anterior chamber. This is a place where intraocular fluid leave the eye. You can see the drainage system of the eye, trabecular mesh, Schlemm canal, and collector's channels. This is the trabecular outflow, and on this picture you can see another scleral outflow through the ciliary body, suprachoroidal space, and then venous circulation of ciliary body, choroid, and sclera. So I think you remember that intraocular fluid is produced by ciliary body, enter in posterior chamber, through the pupil goes to anterior chamber and leave the eye through angle of anterior chamber, through trabecular outflow or scleral outflow. Here you can see the lens, the main functions of the lens are refractive function and participation of accommodation. Here you see the position of the lens. This is the cornea, anterior chamber, iris, lens. Thickness of the lens near 4 millimeters, diameter 10 millimeters, and lens is a unique structure which can change its refractive power. When we look far, lens has a refractive power near 20 diopters. When we need to look near, a lens has 33 diopters. This process we call accommodation. We will speak a bit later during our next lecture how it happened. Lens consists of anterior and posterior capsule, nucleus, and cortex. We go further. This is vitreous body, transparent, colorless gel that fills eyeball and located between lens and retina. Refractive power of the lens near 2 diopters, is not so big compared with the cornea and lens. Also, the vitreous body gives correct form to the eye and support normal intraocular pressure. We have already finished with eyeball, and now we should discuss the accessory ocular apparatus. Accessory ocular apparatus consist of eyelids, conjunctiva, lacrimal apparatus, extraocular muscles, and orbit. We call these apparatus accessories, but this apparatus also is very important for the eye. On this picture, you can see the orbit. The outer wall of the orbit is most rugged, bordered with a temporal fossa. The upper wall of the orbit borders with frontal sinus and anterior cranial fossa. Interior wall of the orbit borders with ethmoid sinus, and lower wall of the orbit borders with Guymerov sinus. On this picture, you can see topography of the orbit. These are extraocular muscles, nerves, arteries. I hope you remember fragments of the orbit. They are very important for nerves, arteries, and veins. I would like mm, to tell you about optic canal. Through optic canal, optic nerve goes out of the orbit and ophthalmic artery enters into the orbit. Superior orbital fissure. Through this structure, all oculomotor nerves go to the orbit, ophthalmic nerve go to the orbit, and superior orbital vein goes out of the orbit. Inferior orbital fissure. Through this structure, infraorbital nerve enters to the orbit, and inferior orbital vein goes out from the orbit. When we have problem in superior orbital fissure, we can see in a patient special superior orbital fissure syndrome. And when you see such syndrome, you can think about pathology in superior orbital fissure, hemorrhage or um, tumor or other pathology. So, in a case of superior orbital fissure syndrome, we can see external ophthalmoplegia, ptosis of the upper lid, internal ophthalmoplegia, mydriasis, paralysis of accommodation. You can see exophthalmos and loss of sensitivity of place in place of ophthalmic nerve innervation. When you see such patients, such syndrome, you should immediately immediately and send this patient to neurosurgeon, to neurologist, and this is very important. Don't miss such syndrome. Now we should speak about extraocular muscles. There are six extraocular muscles, two rectus and four rectus and two obliques. We have four rectus, medial rectus, lateral rectus, superior rectus, inferior rectus, superior oblique, and inferior oblique. Innervation of extraocular muscles. Superior oblique muscle receive innervation, motor innervation from trochlear nerve. Lateral rectus muscle receive motor innervation from abducent nerve, and other rectus and oblique muscles receive innervation from oculomotor nerve. Sensitive innervation all muscles receive from ophthalmic nerve. Lacrimal apparatus we can divide on lacrimal secretory apparatus and lacrimal drainage apparatus. Well, I think it's not difficult to understand that lacrimal secretory apparatus produce tears. There are main lacrimal glands. Main lacrimal glands are situated in the lacrimal fossa, and accessory lacrimal glands, which are situated in conjunctiva. I would like to tell you that accessory lacrimal glands works always and secrete tears which help to wet the eye, to take part in cornea nutrition. Male lacrimal glands work in a case of irritation when we cry or when some foreign body enter into the eye. Okay, now we should discuss lacrimal drainage apparatus. Lacrimal drainage apparatus consists of lacrimal puncta. We have lacrimal puncta in lower lid and upper lid. Then lacrimal canaliculi from lacrimal puncta to lacrimal sac, and from lacrimal sac another lacrimal duct. Tear film, a thin layer of liquid, its thickness just 7 micron. It's situated on the front surface of the cornea epithelium. And I have already mentioned that a tear film is very important for cornea nutrition and for normal condition of the cornea epithelium, and for normal condition of conjunctiva. Nowadays, we often see pathology of the tear film, dry eye syndrome. This syndrome is appeared because of our abnormal ecological situation. We use very often different devices such as phones, computers, and other electronic devices. We sit in dry rooms. We spend just a few time in an open area. So the problem of nowadays is the dry eye syndrome. Also, we often wear contact lens, which is also maybe the cause of the dry eye syndrome. Maybe you also sometimes feel a feeling of foreign body, itching of your eyes. Uh, these are the symptoms of dry eye syndrome. Layers of the T film external layer is a lipid layer, middle layer water layer, internal layer is a mucin layer. We go further. Now we should speak about eyelids. I hope you know that eyelids are located in front of the eyeball. There are upper eyelid and lower eyelid. The structure of the eyelid: outer layer skin, then subcutaneous tissue, muscles, tarsus or connective tissue, and conjunctiva. Conjunctiva covers internal part of the eyelids. On this picture you can see the muscle orbicularis oculi, this is, you see, also structure of the eyelids. And now we should speak about the conjunctiva, which is a transparent thin membrane. Conjunctiva cover sclera, anterior part of the sclera, and internal part of the eyelids. I have already mentioned that there are a lot of accessory lacrimal glands, and the conjunctiva, so these glands produce lacrimal fluid, which wet and lubricates eye. And of course, conjunctiva has protective function because it covers sclera. And you see that conjunctiva always, not always, but very often stop infection which enter into the mm, into the eye. For example, I hope you know that children and adults rather often suffer from conjunctivitis. Yeah, conjunctivitis is inflammation of conjunctiva. So conjunctiva uh, stop infection and um, has protective function to protect internal parts of the eye from infection. We divided parts of the conjunctiva on bulbar conjunctiva, which cava sclera, conjunctiva ponicis, and palpebral conjunctiva, which cover eyelids, internal part of the eyelids. I would like to finish our lecture today. I hope you receive some necessary knowledge in anatomy of the eye. Other more deeper information you will receive through your textbooks. I hope you will attend our practical classes when we can speak more deeply, and you will receive more information about eye anatomy and physiology. Also, I hope to see you on our future lectures, and I would like to say goodbye and have a nice day. See you later. Good afternoon, dear students. We are continue our ophthalmological lectures. My name is Anna Kapayenko. I'm a professor of ophthalmological department. So today the topic of the lecture is the function of vision organ and their aerodynamics, optic system of the eye, clinical refraction. Function of vision organ. Central vision, or we check this central vision by visual acuity, color vision, peripheral vision. We check this peripheral vision by visual field. I hope you know how to check visual field. You started this matter during your physiology classes. Okay, the next function, photo perception, binocular vision, and stereoscopic vision. Central vision or visual acuity, its ability to perceive separately two points located at the minimum distance. It's measured in conventional units. High visual acuity is ensured by the central part of the retina, yellow spot where highly differentiated photoreceptors are located. Here, the central part of the retina macular area, which gives to us central vision of visual acuity. I hope you know how to test visual acuity. The distant central visual acuity is tested by Snellen's test types. There is Snellen chart. On this chart, you can see letters, numbers, different figures, rings, or pictures for children. The principle of all these charts is that the whole optotype, it's a letter or ring or picture. So the whole optotype in any line of the chart is observed under visual angle 5 minutes, detail of optotype at angle of vision in 1 minute. Calculation of acuity of vision is carried out by a Snellen formula. Visual acuity equal small d over big D, where D distance from which examined eye can see the line on the Snellen chart, big D distance from which normal eye see optotypes of the same line. Gradation of visual acuity. You can see the patient which come to see you and says, "Oh, I can't see nothing." But patient can see or zero point 0.1 or zero point 0.2, but for him it's nothing. As for us, as for doctors, nothing, it's a zero. So zero, it's absolute blindness when the patient's eye doesn't perceive the light. The next step, light perceptive. Next, movement of the hand near the face. Next, calculation of fingers near the face. Visual acuity from 0.01 to 0.09. Then visual acuity from 0.1 and higher to 1.0 or even more. So I would like to tell you that visual acuity 1.0 is the average normal visual acuity. There are some patients, some people who can see better than 1.0. Uh, Now we have already discussed how to check visual acuity by subjective method. We ask the patient and the patient answer what he sees. But there are objective methods for visual acuity determination. These are nystagmus apparatus and special laser setting for determination of retinal acuity of vision. Investigation with the help of this method is possible from the age 2-3 weeks when reflex of fixation and leaving traces appear. Rather difficult task to test visual acuity in children under 1 year. The most simple test direct and direct pupillary reaction to light. Then we can use motor paper reaction, construction of pupil, closing of the eyelid, and throwing back the head in bright source of light. Then reflex turning the child's head and eyes to the source of light. Following of the eye slowly moving source of light. From the age 2-5 months, we can use bright red ball with diameter 4 centimeters. Handing on the thread is used. In children 6-12 months, a ball of less diameter we can use. Visual acuity in young age less than in adult. Under the age of 3-4 months, visual acuity doesn't exceed 0.01. In 1 year, visual acuity is usually 0.1, 0.4. In children 2-3 years, visual acuity equal 0.5, 0.6. In 5-15 years, visual acuity usually 1.0. So in this picture, you can see the chart, also Snellen chart, but for children, which help us to check visual acuity for children who don't know letters. Photoreceptor cones, which are situated in the central part of the retina, ensure not only high acuity of vision, but color perception as well. Different combination of three main colors red, green, and dark blue give perception of many shades of painted color. So color vision, its ability of the eye to distinguish colors. Perception of the eye of one or another color tone depends on the length of the wave of electromagnetic oscillation. Colors are divided into achromatic, white, gray, and black, and chromatic, long wave, red, orange, middle wave, yellow and green, and short wave, blue, dark blue, and violet. Color has three parameters. Tone depends on length of the wave of light radiation. Saturation depends on correlation of basic tone and tingles to it. Brightness depends on the degree of closeness to white. Disorders of color vision. Normal color perception we call normal trichromatosis or normal trichromacy. Disorders of the color perception may be congenital and acquired. Two kinds of disorders are distinguished: color blindness and color anomaly. Color blindness is complete defect of perception of one or several basic colors. Color blindness distinguish on dichromasia, protanopia, deuteranopia, and tritanopia. Monochromacy, white and black perception. Color anomaly is a partial disorder of color perception of one of three basic colors. They distinguish protanomaly, deuteranomaly, and tritanomaly. For the diagnostic of color perception disorders, usually we use special charts. Uh, these charts distinguish on basic and control. And using these charts, doctor asks the patient what he can see on this chart. Development of color perception starts from the first day of the child's life. Normal color perception usually appears near 5 to 15 years. In old age, color perception may become worse in connection with senile involution of visual analyzer. Peripheral vision or visual field is a three-dimensional area that can be seen around an object of fixation. Peripheral vision is provided by photoreceptors rods. They are situated in peripheral part of the retina. So here the cones are situated, here rods are situated. For the checking of visual field, we use many different devices: perimeters, spheroperimeter, electronic perimeter, and when we don't have anything, we can use control method where the doctor compares the patient visual field with his own visual field. On this picture you can see the modern perimeter, computer perimeter Humphrey, and here you can see the head of the department who made this procedure. The bodies of the visual fields provide color from temporal side 90 degrees, nasal side and from below 60 degrees, from above about 55 degrees. What you can see the picture of visual field. Here you can see the picture which we receive from computer perimeter Humphrey. Scotomas are defects of visual field. We can relieve these scotomas in perimetry and complementary. Scotomas connected with affection of retina and optic nerve. Scotomas distinguish on absolute and relative, positive and negative. By localization, the scotomas may be central, paracentral, and peripheral. On this example, on this chart, which we received from electronic computer perimeter Humphrey, you can see the central and paracentral scotomas. Hemianopia, defects of half of visual field. And hemianopia is a symptom of brain pathology. So hemianopia may be connected with affection of chiasma, visual tract, and cortical visual centers. On this picture you can see bitemporal hemianopia and binasal hemianopia. Bitemporal and binasal hemianopia is characterized problem pathological area in chiasm. If we see homonymous hemianopia, we can suggest that pathological area is situated upper than chiasm. On this picture you can see different types of visual field defects. So, central paracentral scotomas, tube visual field, peripheral defects, and hemianopias. We go further. Next function of the organ of vision, photoperception, is the ability of the eye to distinguish the light of different brightness. Adaptation, change of color sensitivity in the change of illumination. Adaptation may be to the light, usually near 1 minute, and to the dark. More for this adaptation, it's necessary more time, usually 20-30 minutes. Hemeranopia is disturbance of night vision when the patient has problem in night with the vision. Hemeranopia may be symptomatic In a case of affection of rods and fibers of optic nerve, in retinitis pigmentosa, glaucoma, neuritis of optic nerve, and functional hypervitaminosis A, pathology of the liver, and other diseases. Next function of the organ of vision, binocular vision. Binocular vision is a vision by two eyes. So on the retina, uh, we receive the separate picture. One eye, one picture, and another eye, another picture. But we sees this like one picture. So it's a unique process which helps us to have binocular volumetric vision. Of course, binocular vision has advantages to compare with monocular vision. Acuity of vision, visual acuity of two eyes, is always higher than visual acuity of one eye. Visual field of two eyes in binocular vision is wider, and we can receive, because of binocular vision, volume of the picture. We can use different methods which help us to estimate the presence of binocular vision. Usually we use four dots test. We can use synaptophore, Baglini glasses, stereoscope, diploscope, anisoconimeter. Binocular vision begins to form immediately from the second, third week of the child's life, and usually normal binocular vision we receive near 15 years old. For development of binocular vision is necessary. Two pictures on the retinas of both eyes should be clear and equal in size. Visual acuity of the both eyes should be not less than 0.3. Muscular balance of external masses of both eyes. Muscular balance is normal potential of all extraocular muscles of both eyes. I hope you remember that there are four rectus and two oblique extraocular muscles. And all these muscles should be work in harmony. Okay, we go further, and now we should speak about refraction. Refraction of light, it's a phenomenon of change in the path of light when it goes from one medium to another. Refraction of light in the eye optic system is measured in diopters. Diopter is a refracted force of lens with focal distance 1 meter. Oh, to tell the truth, I think maybe it's a little bit difficult for you to understand refraction, how to check visual acuity, because it's not a medicine, it's more like a math and physics. But you should try to uh, memorize this to understand how to work how to work unique organ which help us to receive clear vision. So The average physical refraction of the eye near 60 diopters. Cornea has 40 diopters, lens near 20 diopters, vitreous body 1.4 diopters, and intraocular fluid, no, just a small refractive power. So look here, this is cornea. Here, usually intraocular fluid, lens, and vitreous body. Here is the retina, where the image should be after refraction. Well, I have already mentioned that there is a physical refraction. So physical refraction characterizes refractive force of the eye optic system. It's a lens, cornea, vitreous body. Clinical refraction characterizes position of the basic focus of the eye optic system relatively to retina. Normally, focus should be on the retina. Clinical refraction may be static refraction in switch-off accommodation and dynamic refraction in switch-on accommodation. Types of clinical refraction are emmetropia. So this is the normal clinical refraction where when basic focus of the optic system is situated on the retina. Call this condition emmetropia. Myopia, also type of clinical refraction, we call it also short-sightedness, and hyperopia or hypermetropia, long-sightedness. The type of clinical refraction depends on correlation of two sizes, refractive force of the eye optic system and the length of the inferior-posterior axis of the eye. How can we check clinical refraction? By subjective method with the help of the glasses, and objective method. Usually we use skyscopy shadow test, and nowadays we use refractometry, autorefractometry. And let's speak a bit more about refraction anomaly. We start from hypermetropia, long-sightedness. Hyperopia is a condition where a person can see distant objects well, but have difficulties in seeing close objects. In this case, the basic focus is located behind the retina, and we should put special lens before the eye to displacing the basic focus on the retina. Myopia or short-sightedness, condition where a person can see close objects very well but have difficulty seeing far objects. The basic focus is situated in front of the retina, and the power of myopia is determined by the force of the lens displacing the basic focus on the retina. Usually we use minus lenses. I would like to tell you the truth that myopia now is like a non-effective epidemic. Every year, more and more persons become myopic. It's a great ophthalmological problem. And if in 20 in 2010 Near 20% of all population around the world was myopic. Nowadays, 30% of the people have myopia, and scientists predict that in 2050, half of the population of the world will be myopic. So, what are risk factors of myopia? The first, visual work on the near distance. It's the most important factor. So nowadays we use computer phones, other electronic devices. That's why a lot of us have myopia. Genetic factors also are important, and reduce glare when the patient or um, has high intraocular pressure. Clinical classification of myopia. We have axial myopia, inferior posterior sides of the eye is more than in normal eye. Refractive myopia, when refractive power of the optic system is more than in a metropic eye. And mixed, refractive power of the eye optic system and its anterior posterior sides is more than in a ametropic eye. Usually we have mixed myopia. By the time of origin, we can divide it all myopia in congenital, early acquired, preschool period, and lately acquired school period. According to degree, we divide myopia on mild myopia, less than minus 3 dioptries, moderate, 3.25 to 6, and high degree myopia more than 6. So, if we can say that mild or moderate myopia, it's like compensation um, of our lifestyle. Uh, High myopia is a rare disease which can be not just a refractive problem, so we can wear glasses and see good, or contact lens. In a high myopia, uh, very often the retina and optic nerve suffer from dystrophic changes. Look on these pictures, please. Here you see the picture of normal eye fundus. You can see optic nerve, macular area, and look on this picture. Uh, you can see here myopic conus or even myopic staphyloma. You can see dystrophic changes in the central part of the retina, pigmentation, this is defects of pigment epithelium. On this picture, you can see hemorrhages, bleeding in the center of the retina, and here you can see very severe dystrophic changes and again bleedings. So um, in such cases, the patients have rather bad visual acuity even with the glasses. So the prophylactic of high myopia uh, is very important part of our work. Okay, there is other refractive error in eye optic system. Astigmatism is a type of refractive error wherein the refraction varies in a different meridian. And you can see the passage of the light rays in a stigmatic optic system. We call this Sturm's conoid. Astigmatism we can divide on physiological, less than 0.5 diopters. It's a normal condition, and pathological, more than 0.5 diopters. Astigmatism may be simple, compound, mix, direct, reverse, with oblique position of the made meridians. How can we correct refractive errors or emmetropies? Myopia, hyperopia, astigmatism. The first line of the treatment of correction of these anomalies, glasses. If the patient don't want to wear glasses or have high degree myopia, hyperopia, astigmatism, we recommend the patient contact lenses. There are some advantages of contact lens. The visual acuity are usually better than in glasses, cosmetic reasons. But on the other hand, there are some disadvantages. It's a contact method. Sometimes contact lenses may be the cause of different conjunctivitis or keratitis, and some patients can't wear the contact lens. If the patient don't want to wear glasses or contact lens, or they need good vision without glasses and contact lens because of his occupation, we can suggest to the patient refractive surgery. Nowadays, refractive surgery is a very popular procedure. Refractive surgery starts from excimer laser photorefractive keratomy. Then, in 1989, appeared laser in situ keratomylosis, or LASIK. It's the most popular operation all over the world. At first, microkeratome form flap, then excimer laser work on cornea, so excimer laser make cornea thinner, and excimer laser changes its form. Then we put flap on its place. Usually, after LASIK, the patient has rather good visual acuity, even after, directly after operation theater, and usually after this operation, patient has rather quickly recovery. The new step of excimer laser surgery is a femtolasic, when the flap is formed not by mechanical keratome but excimer laser, with everything without surgeon, without doctor. Nowadays we have excimer lasers on the sixth step. If the first mm, if the first laser make flattened ablation profile, new laser follow the natural ablation profile, and this gives to our patient very high visual acuity. As for me, why I tell you a lot about excimer laser surgery. I'm excimer laser surgeon, and to tell the truth, I have already made uh, thousands of operations, and I'm really happy that I have opportunity to give to my patient really new vision and new life without glasses, without contact lenses. Okay, now we should speak a bit about accommodation. I have already mentioned that eye it's a unique system, and uh, eye can um, give us opportunity to see far objects and uh, close objects. So uh, it's appear because of accommodation. Accommodation is ability to see objects which are situated in a different distance. So eye is a unique optical device, if it's possible to say. During the accommodation, lens change its refractive power. This is the mm, position of the lens without accommodation, and you can see here lens has already changed its refractive power. You can see on this picture. This is lens for distance vision here, and this lens change has already changed its refractive power, and we can see closed object. Accommodation is characterized by near point or punctum proximus is the nearest point at which person can see clearly, and the far point or punctum remotum is the farthest point at which a person can see clearly. Area of clear vision or area of accommodation, distance from the far point to a near point of clear vision. It's necessary to calculate volume of accommodation. It's a difference in refraction in far point and near point of clear vision. Volume of accommodation is calculated by Donder's formula. A equals P minus plus minus R, where P refraction in the nearest point of clear vision, R refraction in the farthest point of clear vision. As for anomalies of accommodation, there are insufficiency of accommodation, spasm of accommodation, paralysis of accommodation, and presbyopia. Today, I would like to speak with you a little bit about presbyopia. Presbyopia, it's not like a disease, it's a physiological decrease in the amplitude of accommodation associated with the age. So, after 40 years old, lens mm, decrease its opportunity to change its form and to increase the refractive power of the optic system. So the symptoms of presbyopia are the reading distance increased. The patient complains on inability to focus on near work. Um, the patient usually required more illumination for near work. So, I have already told you that it's not disease, but we should help to this patient, to these people, to have a good vision for near. Usually, we prescribe glasses, plus glasses, and there is a special formula for 45 years. Usually, we prescribe near plus one, uh, plus 1.5, for 50 years near 2, for 55 years to 2.5, and for 60 years usually plus 3. I would like to tell that the problem of presbyopia is a great problem in ophthalmology. So, um, for me, rather often come people, come patients who don't want to wear glasses for reading and um, ask me as expert laser surgeon, make me good vision for near. But I can't, if the patient has ametropia, I can't help to this patient. If I make him good vision for near, he will mm, receive bad vision for far and mm, need glasses for far. And nowadays, the problem how to treat, how to um, avoid glasses for reading, it's a great ophthalmological problem. And who mm, who can suggest good and safety and not so expensive method how to help to this patient who don't want to wear glasses for reading for near. I think he will be very famous in ophthalmological world. I would like to say thank you very much for your attention. I hope that during our classes, practical classes, we will have opportunity to discuss visual function more deeper. Okay, and hope to see you in our future lectures. Thank you.